Hello. So we are looking at ParEnteral ion in this video, correct? So far what we have seen, we saw that ion can be given orally or parenterally. Ion normal physiology we saw. Actually, if you see here, it is always absorbed in ferrous form, and heme is also absorbed. So heme also contains ion, right? So remember, people who eat a lot of meat, etc., they will be getting ion in heme form, okay? Then we saw that hemantinics means all these iron forming things. So all of these can be given in the treatment of anemia. Oral iron therapy, we saw that oral is the preferred route. It's cheap and you will give iron salts. You can give ferrous sulfate, ferrous gluconate, ferrous fumarate, colloidal ferric hydroxide and carbonyl ion. Ferrous sulfate has 20% hydrated salt and 32% dried salt. It is the cheapest and oldest, and government actually gives this, but it makes people so nausea, vomity. So anyways, I actually prefer ferrous ascorbate, not there in KD Tripathi. I'm not sure why. The other forms available are ferrous succinate, iron, choline citrate, ferric ammonium citrate. Can you remember all these? Okay, anyways, just remember these. Ferrous sulfate is 20% hydrated salt and 32% dried salt. Then the colloidal ferric hydroxide is 50% iron. Carbonyl ion is actually the highest purity metallic ion. It is available in powder form, but it is prepared by the decomposition of iron pentacarbonyl, which is toxic. Iron pentacarbonyl is toxic. Okay, iron pentacarbonyl is toxic. Okay, shall we move on now? Then we saw the adverse drug reactions of oral iron therapy: nausea, vomiting, epigastric pain, heartburn, bloating, staining of teeth, metallic taste, colic, constipation. Iron causes constipation. You should also know what actually facilitates the absorption of iron and what hinders the absorption of iron. Facilitation of iron absorption is because of HCl, vitamin C, all these reductase enzymes. Heme is directly absorbed. Then you should know that what else? Cysteine, right? Cysteine also helps in absorption. Okay. So all reducing substances like ascorbic acid, whichever contains SH radical like cysteine, all these are going to help in absorption of iron. Now, whatever is going to impede the absorption of our iron, so what is not going to allow the absorption of iron, like if you're taking something that is going to reduce the acid, like if you're taking antacid, then definitely iron absorption will be hindered. They say that calcium and iron should not be taken together, but they have not mentioned in KD Tripathi here. If you're taking phosphates, right, phosphates also are going to complex the iron, so they're going to impede the iron absorption. Then if you're taking phylates, if you're taking tetracyclines, also iron absorption is hindered. Okay, so let us just make a note of that here. So we have made the factors that help iron absorption, factors that impede iron absorption, all that we have done. Okay, now let's move on, guys. So what else? So let us look at the indications for ParEnteral ion. So why would you want to give ParEnteral ion? See, this word is important. Only if oral iron is not tolerated and there are severe adverse drug reactions, if the person is not able to absorb iron, so there's no point in giving it orally. There is non-compliance, whatever you do, the patient is not taking iron, and then you give it parenterally. Severe iron deficiency with chronic bleeding, if this person has, then there's a lot of blood loss and this person already has iron deficiency, severe iron deficiency, then it is an indication for ParEnteral ion. And along with erythropoietin, it can be given. Okay. Along with erythropoietin means, see, oral ion may not be absorbed, okay, if there is a demand of erythropoiesis and you want erythropoiesis to happen, and that is when you give ParEnteral ion. Just write here along with erythropoietin for rapid blood RBC synthesis. Okay. Now, parenteral iron, how do you calculate how much you have to give, right? So, there's a formula here. The amount of iron you give in mg is 4.4 into body weight in kg and into the hemoglobin deficit. Can you say this? 4.4 into the body weight in kg into the hemoglobin deficit, right? In gram per deciliter, whatever deficit, okay? So, what is the normal hemoglobin? Hemoglobin is going to be, in male it is going to be 14 to 16 gram per deciliter, and in female it can be 12 to 14 gram per deciliter. So, based on this you can calculate the hemoglobin deficit and you can tell how much of iron should be given. 4.4 into body weight into hemoglobin deficit. Is this formula clear for you? Please write this in the exam, you will get good marks. Am I audible? Is it clear? Now we are moving on to the preparations. See, iron dextran, old, actually this is old. Nowadays you have iron sorbitol citric acid. This is called as Jectofer or something. Okay. So this is given IM. So don't give it IV, guys. Important, you have to give it IM. So this is called as Jectofer. What is this? Iron sorbitol citric acid. Okay. Iron dextran is a very old form. It is called as Imferon. Imferon. Actually it can be given IM or IV. Iron sorbitol citric acid, Jectofer, IM. Just prick yourself in your deltoid and tell IM. Iron sorbitol citric acid, Jectofer, IM. Okay, I hope you're touching your deltoid and you're saying that you will give it IM only. Okay, everything else can be given IV. Ferrous sucrose, ferrous carboxy maltose. Did we have a sucrose in oral iron therapy? No, we never saw a sucrose, I felt. Was there a sucrose here? No. There was a succinate. Sucrose is only, there was a sulfate and a succinate, but never a sucrose. Sucrose is always ParEnteral. Okay. Okay, can you tell the four iron preparations, ParEnteral iron preparations? Iron dextran. Okay, iron dextran, very good. Iron dextran is also called as what? It is called as Imferon. Imferon. Okay. And then you have iron sorbitol citric acid, then ferrous sucrose, and then ferric carboxy maltose. Maltose, sucrose and all here only. Okay. Sorbitol, don't forget. These are all latest actually. These newer formulations are less risky. They have improved ease of administration, right? You can give it IM, etc. Now let us look at iron dextran, Imferon in detail. So what is it exactly? So iron dextran is high molecular weight colloidal solution. Take a break if you haven't taken a break. Take a deep breath. We are looking at iron dextran. Okay, it is high molecular weight colloidal solution. It contains 50 milligram of elemental iron per ml. What does it have? 50 milligram of iron per ml. Okay, 50 milligram of iron per ml. Fine, it is a high molecular weight colloidal solution. Okay, it can be injected as IM or IV, that we have already told you. In IM route, it is absorbed via lymphatics. Okay, it circulates without binding to transferrin, and it is engulfed by the reticuloendothelial cells. Is it going above your head? So let us just say what all this is. This is a high molecular weight colloidal solution. It has 50 milligram of iron per ml. Then, so in IM route, it is absorbed via the lymphatics. Absorbed via lymphatics. Okay, and then it circulates without binding to transferrin. It is engulfed by the reticuloendothelial cells where iron dissociates and is made available for heme synthesis. Okay. So, can you say it is engulfed?
Engulfed
By
reticulo
endothelial
endothelial
cells.
cells.
Okay, let's just write this much. So look at this IM. We're looking at the IM details, guys. So actually they give it in Z-track techniques to avoid staining of skin. Okay. So basically how you will give this, you will give 2 ml daily or on alternate days or 5 ml on each side, right? So all that is done, it is not given like at once. So over a period of 1 month probably they'll give, okay. The thing with the IM route is that for this iron Dextran, 25% of the dose remains local. So you always have to give 25% extra than what you calculated as the required dose. It is actually absorbed via the lymphatics. It is circulating without binding to transferrin, and it is engulfed with engulfed by the reticuloendothelial cells. The iron dissociates and is available for heme synthesis. Okay. So there can be anaphylactic reactions, so you should be careful. So that is with IM route. Now let us look at IV route. IV route let us look at. So for iron Dextran, IM we have finished. Now IV we are checking how to give. So IV you will actually give test dose. Remember to give test dose for IV iron. Sorry. Here we are. Okay. So how you will give IV? You will give test dose of 0.5 ml and that too over 5 to 10 minutes. You will never give this injection at one shot. It is a slow process. You will give test dose and then you can give 2 ml per day just like IM route. And for every injection you will take 10 minutes it seems. So slowly you will leave the probably line and slowly give slow dose. Okay. Or you can mix the total dose in a 500 ml glucose saline solution and over 6 to 8 hours you will give, and you have to constantly observe the patient. And if the patient has any giddiness, paresthesia, tightness of chest, you should not give. Okay. What did you understand by all this? It's so complicated to give ParEnteral iron, isn't it? Okay. So let us look at the other things here. What are the other options we have? Iron sorbitol citric acid. It is also called as Jectofer. Okay, it is given always IM. Don't give IV. Then you have ferrous sucrose and ferric carboxy maltose, which are given IV. I think these names are a little difficult for you to remember, right? So let us see if you can remember the iron. Iron Dextran is Imferon. Iron sorbitol citric acid is called as Jectofer. Jectofer. Then you have ferrous sucrose and ferric carboxy maltose. Okay. So Z technique, why you are giving Z-track technique of injection to avoid staining of skin in IM route. Okay. It is absorbed by the lymphatics. Moving on guys, let's move on quickly now to what happens if you give excess iron and if a person has taken some kind of iron. Then poison therapy you will do local same stuff. You will give antidote, gastric lavage, all that thing. Now if a person has, if you want to remove the absorbed iron, then you should give desferrioxamine. Okay, desferrioxamine. This is desferrioxamine. Look at it. It is an iron chelating agent. It will remove absorbed iron. Okay. So this is actually given IM again. Otherwise you can give some calcium editate, DTPA. This is also a chelating agent actually, DTPA, that is diethyl N-ethylamine pentaacetic acid. Okay, it's a chelating agent. Okay, or you can give calcium editate. All these to treat excess iron. If you leave excess iron, what will happen guys? Hemosiderosis, hemochromatosis, etc. These are all damaging. So I think we can close this video, right? What have we looked at in the entire video? We saw the oral iron therapy. We saw the adverse effects of oral iron therapy, parenteral iron indications. Okay, then we saw the formula. Then we saw the preparations. Then we saw what to do if excess iron is taken. Okay. Desferrioxamine. Okay, now let us look at the adverse drug reactions of ParEnteral iron therapy. So basically it can be painful, it may cause discoloration of the skin, right? And there could be other side effects like we told you, like there could be hypersensitivity reactions, headache, pyrexia, nausea, vomiting, arthralgia. Because it is absorbed by lymphatics, there could be lymphadenopathy, urticaria, anaphylactic reaction. Okay, so let's write them all down. Say lymphadenopathy, because of ParEnteral iron therapy. Okay, so now let us move on to the uses of iron therapy. Why will you give iron therapy? You can give it as a treatment for anemia. You can also give it as prophylaxis in pregnancy, etc. So to treat iron deficiency anemia, this will be microcytic hypochromic, right? Hypochromic anemia. So you can also give it as prophylaxis, right? Like in pregnancy, infancy, so that iron deficiency does not crop up later. Okay. So these are the main two headings that you should write. Now coming to iron deficiency anemia or microcytic hypochromic anemia, like this can happen because of a lot of reasons, nutritional iron deficiency or poor iron absorption, etc. So you can give oral iron in this case. And if the iron anemia is not very severe, right, and if the person is not going into any delivery, right, if they are not going into childbirth, then you can probably prefer oral iron therapy, right? So 200 milligram of elemental iron is required per day. How much will you give? Right, you will give for 4 to 8 weeks you give, then you will check hemoglobin levels should be checked. Okay. Then again you will continue to give iron for 3 to 6 months to replenish the iron stores. Okay, so you should continue even after hemoglobin reaches normal level. Now let us move on to prophylaxis, guys. Prophylactic iron therapy is usually indicated for pregnancy, infancy, etc. Prophylactically, it is given to meet the increased demand of the growing fetus and the uterus and to combat the loss during labor. For prophylaxis, how much you will give? 100 milligram of elemental iron per day, right? It is given in second trimester. Why? Because in first trimester there will be nausea, vomiting. Okay, right? What else, guys? Folic acid is anyways given in first trimester or even before conceiving. So as of now, if you remember about iron, it is enough. For prophylaxis, 100 milligram of elemental iron per day. And if there is iron deficiency, then you can give 200 milligram of elemental iron per day. That's all, guys, we wanted to cover. Excess iron, if there is there, you will give desferrioxamine. This is for acute iron poisoning. Other options are DTPA, that is diethyl N-ethylamine pentaacetic acid. It's a chelating agent, or you can give calcium editate. Okay. Remember desferrioxamine. Okay. For iron poisoning. Desferrioxamine.